following. Let me see if I can share my screen. All right, now let's adjust here. Okay, how does this look to everyone in the audience? Good? Okay. You can hear me okay as well? Okay, wonderful. Well then, I'll go ahead and get started. So my name is Tejas Patil, an assistant professor of thoracic oncology here at the University of Colorado. And my talk today will really just focus on biomarker testing in advanced non-small cell lung cancer. And what I really hope to do in the context of this talk is give some practical tips about how do we utilize biomarker testing, what goes into different tests, and then some basics about the various pathways that we use and manage in lung cancer. So go to my next slide. So these are my disclosures. In the past 15 years, the field of thoracic oncology has experienced rapid growth. And what this paper shows, and many other papers more recently are showing similar findings, is that lung cancer really has been able to clearly identify a number of driver oncogenes. And when we say driver oncogenes, what we really mean is that when we look at these mutations, and so here I'll use the example of EGFR on the right-hand side, we believe that this mutation plays an active role in facilitating cancer growth. And this figure really nicely illustrates that approximately 56% of these non-small cell lung cancer samples have mutations that are targetable with currently available agents. Actually, sorry, I misspoke. It's about 45% as of 2021 with currently available agents. And then there are several that are in trials, such as FGFR, that I'm not including right now. So why does this matter? Here I pulled up some data from the NCI SEER cancer statistics from 2021. And it still remains the case that lung cancer is the second leading cause of cancer incidence in both men and women, and the leading cause of cancer death in men and women. And if you estimate that about 235,760 cases of lung cancer will be diagnosed in 2021, and let's assume that 84% of these are non-small cell lung cancers. So we're going to leave out the small cell cancers, and as they are sort of different biology and have different properties. And we assume that 45% of these have a driver oncogene, then we're left with 88,424 cases of non-small cell lung cancer with a driver oncogene. And to put that in context, we think of pancreas cancer as this exceptionally lethal cancer, and there's been many incidents of high-profile celebrities getting this, but the total number of pancreatic cancer cases in the US in 2021 was 60,430. And so the point here is that driver oncogenes in non-small cell lung cancer, while thought of as rare, are actually quite common when you look at them in the aggregate. This is a current list of oncogenic drivers with FDA-approved therapies, though I had to update it this year because in May 21 of this year, amivantamab was approved for EGFR exon 20 insertions. And then in May 28, sotorasib was approved for KRAS G12C mutations. And what I haven't included here is some of the important developments that's happening in the HER2 exon 20 space with mobocertinib and trastuzumab deruxtecan. So let's go back to the basics. Let's talk about pathology 101. So when we think of biomarkers, it's really important to know the sources of the tissue that we get. And so when we get a block of tissue, we're typically talking about a paraffin block that has been embedded. It's really important to recognize that this is a finite resource. When the block has been cut numerous times and there's nothing left, we think of it as exhausted. And so this oftentimes has to be really carefully thought of as how do we want to do testing and what do we want to prioritize. For completeness, we'll also talk a little bit about H&E. So this stands for hematoxylin and eosin stain. This is the stain that pathologists use to assess the tissue, and it's typically part of the permanent record. And here you can get morphological assessments of how a cancer appears. And in this case, we have an example of an adenocarcinoma. And FFPE is formalin fixed, paraffin embedded. This is a common form of a stain that you would see in a lab. And this has implications for DNA and RNA testing, which I'll talk about later. So with more and more targeted therapies entering into the clinical space, it's really helpful to think of the trade-offs that are involved with biomarker testing. And here there are two central concepts that I really want to emphasize. One is the concept of clinical sensitivity. How many possible mutations can a test detect? And so when we see false negatives in a test, it's largely because of the test design. And so a very good example of this is a PCR assay for EGFR that really is sensitive and is really optimized to look for L858R and exon 19 deletion mutations. So if the G719 or exon 20 insertions are not in the test parameters, it's not going to ever pick them up. And that trade-off there is an indication of clinical sensitivity. Now, analytic sensitivity is a different issue. It has nothing to do with the test. It has everything to do with the tissue. So how well can a test detect a rare change among normal? And so you can think of a situation where you get pleural fluid or pleural cell block that has a lot of mesothelial cells, very, very few tumor cells. But if you have a test that's optimized to look for a very, very specific mutation, it will pick that mutation up even in that cell block. And so another way to think of this in clinician speak is clinical sensitivity is the test can identify many needles in a haystack, but they have to exist at a pretty high level. And analytic sensitivity is the test can identify only a couple of needles, but when they're very, very small and very rare, it can pick them out. And when we think of biomarker testing, there's always going to be a push-pull between these two sensitivities, clinical sensitivity and analytic sensitivities. And we'll talk a little bit about this as it relates to testing methodologies. So in molecular testing, there's four main categories that we typically think of. One is called immunohistochemistry. The other is FISH. Then there's PCR, which there's various iterations of that, and next generation sequencing. So immunohistochemistry is one of the more standardized ways to look at cancer cells and answer questions about molecular biology. So it selectively identifies antigens or proteins in the cells of a tissue by use of specific antibodies. Here, visualization can occur in one of two ways. So you can have what's called a chromogenic IHC. This is where an antibody is conjugated to an enzyme that catalyzes a color-producing reaction. The alternative is to do what is called immunofluorescence, and here an antibody is tagged to a fluorophore. And so on the right here, you see an example of non-small cell lung cancer. And in this case, the standard stains that were used were TTF1, which is typically positive, napsin A. You'll typically have P40, P63, which are markers for squamous cell carcinoma, and then CK7 and CK20. So the practical applications are as follows. We can use immunohistochemistry to confirm an ALK gene rearrangement. And here we specifically use the D5F3 antibody. And this can be really useful in resource limited settings. So in parts of Asia where there's limited access to healthcare, or even in rural communities where the ability to do next generation sequencing might be limited, an IHC positive antibody, or rather an IHC test that's positive using the D5F3 antibody can really confirm that a patient has ALK positive lung cancer, and this has implications for treatment. It is used to determine the PD-L1 tumor proportion score. We'll cover this a little bit more later in the talk. And finally, it can be used as an target for antibody drug conjugate trials. And so here, what we're looking at are various antibody drug conjugates and their targets and the relevant clinical trial that's ongoing. And just to be clear, an antibody drug conjugate is essentially the formation of or the use of a monoclonal antibody coupled to a linker, coupled to a payload. And the payload typically has some form of chemotherapy, which if given IV on its own would be extraordinarily toxic. But because it's set up in this specific way where it's coupled to an antibody, it can be delivered in a more selective format. And the way we screen for these is by using IHC. So fluorescent in situ hybridization is another method that we use in molecular testing. Most FISH procedures use fluorophore-coupled nucleotides as probes to examine the presence or absence of complementary sequences in fixed cells or tissues under a microscope. And the key points to emphasize here is that we typically use this for gene fusions and gene amplifications, the most common being ALK and ROS1, which by definition, if greater than or equal to 15% of the nuclei out of 100 are positive, then we consider the patient to have an ALK gene rearrangement or a ROS1 gene rearrangement. Now, you could do this for NTRK and RET, but it's much less frequently used. And in the era of next generation sequencing, which we'll cover later in this talk, this is sort of less commonly used. Gene amplifications are also very useful, to detect through FISH. And here we're specifically looking for MET and HER2, although in principle, you could look at many other genes. So ALK is a really good example of using the FISH-based testing to detect for gene rearrangement. And so what happens here is that you have two differentially labeled short DNA sequences that flank the breakpoints of the ALK gene, which occurs as a fusion from an inversion on chromosome 2. And what happens is that the short distance is called a subtle split signal between these red and green parts of the probe. You can get overlap signals on a kind of an image, and you can then confirm that you have the fusion. So it's probably easier to just show with an image. Let's see if so actually, let me go back one slide here. So here you can see that you're using different fluorescent probes here. And if you have a green and a red signal in kind of close proximity to each other, and you're specifically knowing that you're looking for an ALK rearrangement, you're going to look for the green red fusions, and that kind of alludes to whether you're dealing with an ALK rearrangement. Now, the probes themselves can be anything. So in acute promyelocytic leukemia, you could look for PML, RARA, there's there's translocation 1517 more specifically. So there's all kinds of probes that can be used, but the technique is fundamentally the same. A major issue with FISH is that FISH requires a lot of tissue. So remember, we talked about tissue being a finite resource. And in lung cancer specifically, obtaining tissue, especially if it's from a lung biopsy, there are complications that are associated with lung sampling. And so we have to think and keep that in mind when we order FISH-based testing. Another useful for FISH is in determining gene amplification. So with FISH, you can localize a gene sequence of interest and compare it to a centromeric portion of a chromosome. And it can really separate out two different scenarios. So one is called polysomy and the other is called amplification. So what's happening in polysomy is that due to chromosomal instability, where you can have multiple chromosomes dividing, and this happens frequently in very poorly differentiated cancers, you'll have a high level of, or a high gene copy number that's shown here in red. But what FISH can do is it can also pair it to the centromeric portion of that same chromosome. And so you can then get what's called a ratio of the gene to centromeric portion ratio. And if it's close to 1, which is what you would see in polysomy, this is not true gene amplification as a kind of genetic event, but rather just chromosomal instability writ large. But if you have gene amplification, which we don't quite understand the mechanisms of how gene amplification occurs, but it's thought to be related to breakage and fusion bridge cycles. Nonetheless, if you look at gene copy number and compare it to the centromeric portion of the chromosome, you will see that that ratio will be greater than 1. And typically in breast cancer, where this has been most well validated, the cutoff is greater than or equal to 2. Now, whether that applies in lung cancer, we don't know. And there's a whole area of controversy about what's the optimal cut point for gene amplification. Sinead Noonan, who was a fellow at our institution, put a really nice paper out to kind of address this question with MET amplification. And one of the challenges with gene amplification is that you can coexist with other drivers. And so it's been unknown really what is the optimal gene centromere ratio that defines true amplification. And in this paper, which was kind of a nice retrospective series, what she showed was that if you have a MET to chromosome 7 or centromere 7 ratio greater than or equal to 5, there basically was no other oncogenes that overlapped in this situation. And this probably might be a candidate scenario which would define true gene amplification. But again, this is just for MET, and this controversy would extend with other genes. So if we're talking about HER2 or EGFR or whatever. So again, a lot of nuance here, but the fundamental point is that FISH can potentially help distinguish between polysomy and gene amplification. And this does have therapeutic implications. The third method of biomarker testing is something called PCR, polymerase chain reaction. And this is really useful when we have a very specific target that we're looking for, especially if it's a very specific point mutation or a deletion. So really good examples of this are when you're looking for an EGFR L858R mutation or a BRAF V600E mutation. So I like to think of PCR as molecular photocopying. What happens here is you identify a DNA region of interest, you identify some primers for that region of interest, you denature the DNA by heating it, and then there's thermostable Taq polymerase that can create new strands of DNA from those primers, and then you just rinse and repeat, rinse and repeat. Now, there are modifications to this method. There's reverse transcriptase PCR, sometimes abbreviated as RT-PCR, which makes mRNA as a template, uses reverse transcriptase to make a DNA template, and then rinses and repeats it. There's also multiplex PCR, where you look at more than just one sequence. So you have multiple sets of primers being amplified in a single PCR mixture. Now, the limitations of PCR are best shown here with EGFR exon 20. And while PCR is really good when you're looking for a very specific mutation, so an EGFR L858R is a very specific mutation that is well optimized and well studied through PCR testing. When you're looking at something like EGFR exon 20 insertions, this becomes really problematic. And part of the problem is that EGFR exon 20 is a diverse subset of mutations. And it's very difficult to design primers and probes to cover every possible alteration that would fit an EGFR exon 20 insertion mutation. And the nomenclature has been really complicated as well. So this is an example where potentially PCR testing might miss a lot of these subtypes, which gets me to next generation sequencing. So the first and most important point I want to emphasize is next generation sequencing is a platform. It is not a standardized test. There are many companies that will do next generation sequencing. Some of these include Foundation Medicine, KRAS, Tempus, Archer, and so on. And it's important to emphasize that each of these companies will have their own gene panels and their own gene libraries. So what is reported and what is covered is oftentimes, while there's a lot of overlap, there are some panels that will cover certain genes and not other genes. So it's important to remember that. Some alterations are more challenging to report from a bioinformatics perspective, and these include gene fusions, gene amplification, which we'll talk about, and tumor mutational burden, or TMB. It's really important to recognize the differences between DNA and RNA-based NGS testing. And we'll cover this in subsequent slides, but RNA is particularly useful when the fusion partner is rare, where it's not very well defined. So examples are ROS1, NTRK, and MET exon 14. And a word of caution about gene amplifications through NGS platforms. So when we looked at FISH, we had a method to look at the gene copy number and compare it to the centromere, and we could look at ratios. The problem with gene amplification when it's reported through NGS platforms is they basically take the gene copy number and then they kind of do a bell curve distribution and and look for what is the 95th percentile of that gene copy number. But it's not standardized to the individual gene itself, meaning so at FISH, you're standardizing it to the chromosome. But with NGS platforms, a lot of this is based off of statistical probability based off of their own internal data set. So you have to really interpret gene amplification with caution when reading an NGS report. There are different types of NGS, as I had alluded to earlier. We had talked about DNA NGS through capture, but then there's also RNA-based NGS, and here we have amplicon and capture as well. And the way I like to distinguish these two is to really go back to the basics of biology between DNA and RNA. So in DNA, there are these large repetitive sequences called introns, and they're really hard to sequence because you have to essentially have probes for every possible combination within an intron, and that can be very, very difficult. And where this becomes particularly challenging is if we have a gene fusion where, like, let's say we use ROS1 as an example. So ROS1 is a gene fusion or a gene rearrangement. We know that ROS1 is one end of the gene, but its partner could be somewhere in the entire intronic sequence, and we may not know it unless we have primers for the entire sequence. Now, you can just avoid this whole problem altogether by just looking at the RNA, because what happens when going from DNA to RNA is that the intronic sequences get spliced out. And if you look at the final product with RNA, then you can really get a good sense of what are the gene fusions. And you can also have a better sense of when you're looking for novel fusion partners through an RNA-based approach. Now, the big trade-off with RNA is that it really depends on the quality of RNA. And so this is where that comment about FFPE slides, and in particular bone specimens through the decalcification process, you can really compromise the quality of RNA. And so this is an issue with RNA-based testing. I'm going to skip this slide for now and go to here. So this was work done by Kurt Davies, who showed in a very nice paper that when you use DNA-based analysis looking specifically at MET exon 14 mutations, which are a complicated mutation, we'll cover this in a subsequent slide. But the problem with these mutations is that a lot of their amino acid sequences are in intronic sequences. And so it's very difficult to a priori predict them based off of a DNA-based analysis. And when you use an RNA-based analysis, you can in fact improve your detection rate. And then this is what I would consider a seminal paper in molecular testing. So by Benayed et al. This is from the Memorial Sloan Kettering group. And what they did was they looked at 2,522 cases of lung adenocarcinomas, of which 589 were, quote, driver negative. So these were patients where they had full sequencing done and nothing was found. And within that, they took 275 of these, did RNA extraction, and then sequenced 254. And what's interesting about this is approximately 15.5% of cases when they did this process, so they used the RNA-based assessment, they did find driver oncogenes that were previously identified as negative. So this leads us to how do we manage patients now? I would say that in general, and the NCCN is pretty clear about this, broad-based molecular testing is recommended for any patient with lung cancer. Recognizing that tissue is a limited resource, I think it's imperative that we, at the bare minimum, test for EGFR, ALK, ROS1, and BRAF. At the bare minimum. I would actually argue that in the modern era, we should also be testing for RET and MET. And the main reason to do this is because there are targeted therapies available for all of these oncogenes, and they have huge implications for patients moving forward. These are the current actionable oncogenes as of 2021 and the modality in which they're frequently tested. A couple of comments here. I would add that we don't typically use IHC for MET and HER2. I included them here because there's a lot of antibody drug conjugate studies that are ongoing with MET and HER2 as IHC targets, but in clinical practice, it's pretty common to really spend some of the tissue on ALK and PD-L1, and these middle three we don't typically use. The other thing I want to mention is that we talked about amplification being maybe potentially better through FISH-based assays, and here I specifically am referring to MET and HER2. Yeah, okay, so we talked about that. So let's talk a little bit about some of the common mutations and then typical targeted therapies that we would use for these patients. So the EGFR pathway is a very, very common pathway in both normal biology, and then mutations within the EGFR pathway result in lung cancer. Normally, it requires an EGF ligand to initiate signaling, and upon ligand binding, the regulatory C helix pivots from an outward inactive conformation to an inward active conformation. And so that's shown on the top left going into the top right. And what happens is when that C helix moves in, you get phosphate binding loop of the active site. In the bottom left, what's going on here is that you have what's called, this is an example of an EGFR exon 19 deletion. So deletions essentially pull this alpha C helix into a locked inward active conformation. And what happens is now the ATP binding site is essentially exposed, and you get an asymmetric dimer interface, and you get sustained EGFR activity and oncogenesis. And so one of the things that a very wise medical student asked me in clinic once is like, well, if you have an exposed ATP binding site, so looking at the bottom left, and a wild type EGFR that's active, looking at the top right, how does EGFR drugs work? Because wouldn't it just affect wild type and the mutant equally? And that's a really, really good question. And the truth is that despite having exposed binding sites, there are differences between activated wild type and mutant EGFR. And it has to do with the fact that these conformational changes that happen within the exon 19 and L858R, even though the binding site is exposed, there are actually amino acid sequence changes that result in lower affinity for ATP in the mutant state than the wild type. And so because there's lower affinity for ATP, it makes it so that drugs such as EGFR inhibitors have a better chance of inhibiting that binding pocket than traditional ATP does. And this is a kind of an unusual property of these mutations that we can actually do this. And so you will notice that with the EGFR exon 20 insertions, where you get a push from the C-terminal side, they have sustained affinity for wild type ATP. And so one of the common problems we've seen with exon 20 insertions is that whenever we put patients on clinical trials, because there's this sustained affinity for ATP, you get a lot of wild type EGFR side effects. And so many of the EGFR exon 20 drugs cause tons of diarrhea, tons of rash. And these are all because these are where EGFR is expressed in the body. So knowing that your patient is EGFR positive is not enough. You have to know which mutations are sensitizing to the TKIs. There's drug-sensitive ones like exon 19 del and L858R. There's less drug-sensitive ones, and then there's some insensitive ones. And for the exon 20 insertions, in general, I put these patients on a clinical trial. There's been newer data with amivantamab that looks very encouraging. It works very differently than these pill-based treatments that I'm talking about. It's a bispecific monoclonal antibody. And then if you had to use standard of care treatments, afatinib, osimertinib, or erlotinib in terms of TKIs are your best options. Let's talk a little bit about BRAF. So BRAF is part of the mitogen activated protein kinase, or the MAPK pathway. It has a major role in regulating cell growth and regulation. So in healthy tissue, BRAF kinase is deactivated through negative feedback once the signal has moved on to the next point of the cascade. And what's happening with a BRAF V600E mutation, again, here it's shown, it's kind of small and hard to see, but if you look at this yellow box here where you see the BRAF V600E mutation, what's going on is that you have a mutation that results in constitutive activation of the MAPK pathway. And so when they first were looking at drugs, and here melanoma was the first space where these drugs were being explored, the initial use was to develop a BRAF inhibitor. And so there was a lot of work looking at drugs like dabrafenib on its own. And the initial trials used dabrafenib, but what they invariably found was patients develop resistance really, really quickly. And it happens because there's redirection of cell signaling to MEK. And so we found out through clinical experience and really good preclinical science that you really have to inhibit RAF and MEK simultaneously. And so this is what's led to the approval of a combination therapy, dabrafenib and trametinib, for the V600E mutants. A key point I want to emphasize here is you do not use this combination for patients who have atypical BRAF mutations. So there's mutations such as G465A. There's a whole host of BRAF mutations that do not have the same mechanism, and they have different mechanisms of resistance. And it is not recommended that you use dabrafenib, trametinib, or a RAF MEK inhibitor in these patients. Gene fusions are common in lung cancer, and they encompass a wide variety of oncogenes. I've listed some of them up here. So there's ALK, ROS1, RET, NTRK, and NRG1, which is a very interesting fusion because we'll talk about it a little bit at the end of this slide, but it basically generates a chimeric protein that functions as a ligand. So it doesn't actually itself generate constitutive activation. It generates a ligand that then generates constitutive activation, which is somewhat unique. So a gene fusion occurs when a hybrid gene is formed through erroneous rejoining and replication of DNA, and you get fused RNA transcript and abnormal, or sometimes the term used is chimeric fusion protein. The key point here is just to remember that fusions in lung cancer are sensitizing. So you will get an NGS report, and sometimes you'll see things like an NTRK point mutation. This is not a patient that you should be starting larotrectinib on. In general, it's the fusion, not the mutation. Now, there are rare cases in other tumor types where mutations are sensitive. So for example, in pediatric neuroblastoma, ALK point mutations are common and activating. In thyroid cancer, we've oftentimes seen RET point mutations that are activating, but in lung cancer, in general, we need to think of these as fusions. And here is where RNA-based NGS may be potentially better at detecting fusions with novel partners. Let's briefly talk about HER2. So compared to other ERB family members, HER2 has no known ligand. So it's a very interesting oncogene because there's nothing that binds to it. It rather activates through heterodimerization with other ERB family members, such as ERB1 or ERB3. And in cancer biology, HER2 can be altered through gene amplification, and it's very common in breast cancer. In lung cancer, what's more common is actually HER2 exon 20 insertions. And so these actually have more in common with the EGFR exon 20 insertions that I talked about earlier. And it's partly because they're very structurally homologous to them. A big issue has been that therapy has been very difficult to come by for this subgroup. There's been developments in this space. So most recently, there's been very promising and compelling data from an antibody drug conjugate called trastuzumab deruxtecan, and also mobocertinib. And I need to update these slides to reflect that, but that's where the space is going, and there's additional therapies coming out within next year in this specific space. MET is a very complicated pathway. I'll try my best to very simply cover this. What occurs in the MET pathway is you have this, so that's shown in the picture on the left-hand side. You have an HGF, which is a ligand, and it binds this pathway, and then there's a whole host of kind of very complex interactions that occur. When we say MET alterations, it's a very heterogeneous group. And we could be talking about MET overexpression, which has been associated with a poor prognosis. We could be talking about gene amplification. We could talk about aberrant splicing, and so that's when we say MET exon 14 mutations, is what we're talking about. Or we could be talking about MET gene fusions, which are very rare but do occur. And so one example of how RNA-based NGS testing could be helpful is with the MET exon 14 mutation. So I just want to spend a little time on this. So the MET exon 14 mutation is a really good example where you have an association between splicing and oncogenesis. So what normally happens is that introns flanking the MET exon 14 are spliced out, and then you get an mRNA that contains the MET exon 14 and it's translated to a functional MET receptor. And the MET exon 14 encodes this part of the juxtamembrane domain here shown in green, which is the CBL site. And so what this CBL kind of binding site does, it's called ubiquination. And what it does is it targets this receptor for degradation and says, okay, signaling is over, we need to shut it off. And MET exon 14s actually result in aberrant CBL proteins so that they can't actually turn the receptor off. And so you just get ongoing signaling. And so this is an example of signaling through loss, because this is not technically an activating mutation. This is a mutation that results in an inability to degrade the MET pathway. And here, the current therapies that are available are capmatinib, tepotinib, crizotinib, and there's many other MET therapies that will be emerging in this space. KRAS has been all of the rage in 2020 and 2021 because this was historically described as an undruggable target. And more recently, there's been a drug, sotorasib, that has been approved for patients with stage 4 lung cancer who've progressed on a platinum pemetrexed, pembrolizumab, or some kind of chemoimmunotherapy combination are eligible to receive this therapy. So RAS is a very common oncogene in cancer. It involves the RAS, RAF, MEK, ERK pathway. And basically, if you have GTB bound, you have an active form, and GDP bound is inactive. And it turns out that you have a limited number of mutations that cause oncogenesis, and they typically involve codon 12, 13, and 61. So when you say a KRAS G12C, it's involving codon 12. If you say a KRAS G13C, it's involving codon 13, et cetera. What sotorasib, and there's another drug in market called adagrasib, do is that they irreversibly bind the mutant cysteine. They disrupt switch 1, 2, and lock the KRAS into this GDP-bound state, and then you don't get RAF signaling thereafter. Now, what's interesting here is that the response rates are not as high as other oncogene drivers and are within the 30 to 40% range. And so this tells us a lot about the biology of RAS. And what I suspect is going on is that there's a lot of bypass signaling involved, and that the cancers are just recruiting other cell signaling pathways to survive. This is an area of active research. Let's talk about PD-L1 in lung cancer. It's important to know that PD-L1 is not a mutation. It is rather a biomarker that lets the clinician know how effective will immune checkpoint inhibitors be in a specific patient. One of the challenging things about PD-L1 is that each company has their own companion diagnostic IHC test. So common ones that we frequently see are the bottom two. So SP263 is frequently associated with the atezolizumab. So this is the Ventana assay. And then the 2263 is the Merck assay with pembrolizumab. This is called the DACO22C3. And what PD-L1 allows us to do is understand, well, first of all, it's important to know that it's reported as a range. And trials will use different cutoffs, but this can be very arbitrary. So in Keynote-024, which was the landmark trial looking at pembrolizumab, they used a PD-L1 score greater than or equal to 50%. And then in Pacific, which was a trial looking at durvalumab in patients with unresectable stage 3 non-small cell lung cancer, when going back in time and doing subset analyses, they used a PD-L1 score of greater than or equal to 25%. This wasn't used as an inclusion criteria for the study, but it nonetheless reinforces the point that there's no real cutoff point. And there's a lot of trials that'll look at PD-L1 greater than or equal to 1%. So just to recognize that. We talked about the different companies having their own diagnostic assays. And one of the biggest issues I've seen is that companies and trial literature will collapse PD-L1. Remember, it's a continuous variable from 0 to 100% into a categorical variable, high or low. And this matters because this is a very, very nice paper from Aguilar et al. In Lancet Oncology, that they looked at these patients that they called PD-L1 high. These are the ones we expect to do better with immune therapy. And what this paper really showed was that it actually matters where you are when you say PD-L1 high, because it turns out that the patients who are 90 to 100%, they're disproportionately driving the response to therapy. So when you evaluate and appraise trials that use immunotherapy in the literature, it's really important to know, why did they choose a PD-L1 cutoff of 1%? A lot of trials will do this. And so it's important to really get an assessment of the full range of PD-L1 expression. There's a word on waiting for molecular testing. So in general, we think that there's a divergence between targetability and immunogenicity. Patients who have ALK or ROS1 fusions, shown on the bottom right, have historically had very poor responses to immune therapy. And there's emerging data to suggest that giving these patients immunotherapy and then switching them to a targeted therapy actually worsens the side effects of their targeted therapy. And that'll be covered on the next slide. On the other hand, we know that there are many mutations where there's a high degree of immunogenicity, such as KRAS or non-V600E BRAF mutations, where immune therapy seems to work really, really well. And so I think what's key here is to really, really wait for molecular testing. At the bare minimum, wait for RET, EGFR, ROS, and ALK, because these patients almost uniformly do not benefit from immune therapy. This was what we talked about earlier, which was that you have higher rates of immune-related adverse events with sequential immunotherapy and targeted therapies. These checkpoint inhibitors have really long half-lives. So when you give someone immune therapy, it is in their system and their T cells have been activated, and it'll be like that for months. So at the bare minimum, wait for EGFR, ALK, ROS1. I would also add RET to this slide before starting chemoimmunotherapy. Now, there's been a big move to doing blood-based molecular testing. We know that tumors shed DNA into the bloodstream, and it's mostly correlated with tumor cell death. And small units of DNA can be protected through histones. And so what we can do is we can actually extract these and analyze these. And there are many companies that do this. And so I thought the best way to cover this information was to actually just use case examples from patients that I took care of. So here we're using data from a company called Guardant. And this was an example of a patient's report. This was a 62-year-old woman, never smoker, with ALK rearrangement. And the Guardant report is shown above, which is basically we found nothing. So this is not a test design issue. This is actually, when we talked about clinical sensitivity and analytic sensitivity, this is an analytic sensitivity problem. The disease is entirely intrathoracic. And so what happens is when you have lung-only cancer or lung-only metastases, there's a much lower burden of disease, and it's harder to detect via blood-based assays. Had she had the same cancer, but it had involved the liver or some kind of organ where there's a high degree of blood flow, they would have probably picked up the ALK rearrangement. This is a 58-year-old woman with a 30-pack-year history of smoking, and she has a KRAS G12C mutation. This is useful. This is very useful because further testing is unlikely to yield an actionable driver. I may have not explicitly mentioned this, but it's really important to know that in general, one of the fascinating things about oncogenes in lung cancer is that they rarely tend to overlap with other oncogenes. You're rarely going to find a KRAS G12C and an ALK mutation, or KRAS G12C and an EGFR. They don't overlap. And so in this situation, knowing this KRAS G12C mutation helps you because now you know, okay, we can do chemoimmunotherapy, and in the back burner, I can use sotorasib if I need to. This is an interesting Guardant report. So this was a patient who was a 65-year-old with a very heavy smoking history, had previous chemotherapy and immunotherapy, and then we did this blood-based test. And all of these alterations, look at this must be very, very helpful. And the truth is, no, none of this is useful. These TP53 mutations and IDH1 mutations essentially are just coming from chemotherapy. So you kill a ton of cancer cells. Remember, we said that the assumption is that what you can detect in the blood is proportional to, let me go back a couple of slides just to make sure, mostly related to tumor cell death. So what you're seeing here is just the effects of chemotherapy. A lot of cells are dying. You're seeing a lot of different TP53 mutations. None of these are oncogenes. So this is an example of a Guardant blood draw that was done in the middle of therapy. And this can sometimes yield confusing results. And so it's important to be able to interpret this. Some caveats on circulating tumor DNA is that they're very, very specific. So if I find an EGFR mutation or I find a KRAS mutation, that's very useful. But if we don't find anything, it's not informative and you still need tissue-based testing. They are DNA-based assays. So RNA unfortunately degrades too quickly in the blood, so you can't really generate RNA-based assays. And this has implications for gene fusions because there's only a limited number of primers that you can develop for patients with rare gene fusions. And so tissue-based testing can still be very useful here. And the other thing is to be very careful in over-interpreting what's called the variant allele frequency. So sometimes these tests will give the percentage of which the mutation is detected in the blood. They'll kind of report it as a percentage. And it's important to know that the yield is proportional to the blood flow in the relevant organ site. So this was what we talked about in the first case with that woman with the ALK rearrangement. If you have lung-only disease, it can sometimes be very difficult to detect anything. Likewise for brain-only disease. If you have brain metastases alone, it can be very difficult to detect anything on these circulating tumor DNA assays. And these continue to evolve. I didn't and will not in this slide talk about minimal residual disease, but that is an area of active research right now. So in summary, I just wanted to emphasize the importance of biomarker testing in lung cancer, understand some basic principles of testing, understand common testing methodologies and their limitations, and really recognize the real world use of biomarker testing in lung cancer. And with that, I'll take any questions.
Thank you. Thank you. I actually have a quick question. So I'm going to try to say this right because I try to keep it clear in my mind. So you have wild type, and you have acquired. How do you acquire a mutation?
Oh, yeah, that's a good question. So we don't really know, actually, is the short answer.
Okay.
Yeah, there's not a clear link. So I should have also mentioned that when we say we're doing molecular testing, I was very careful to use the word molecular testing and not genetic testing. A lot of the times we don't think of many of these mutations in lung cancer as being hereditary. So this is very different than in breast cancer and colon cancer where there are clear genetic links. With EGFR, we don't quite understand why some patients develop a sporadic mutation in that domain and then get cancer from it. It's actually an area of ongoing research.
Okay. Let's see. Do I have anything in the chat? Does anybody have any questions? Okay. Thank you so much for presenting today. I really appreciate it. That was really very informative. I got a lot out of it. All right. Thank you and have a good weekend.
Thank you.
Okay, guys, I would really, really appreciate like feedback and suggestions from y'all on what you would future, what you liked, what you didn't like. If you tell me you didn't like it comes in an email, I won't mind. I won't hold it against you or anything. So don't feel like being anonymous is a big thing. And then once I get this downloaded and everything, I will get it sent off to everybody so that you can see the recordings and the slides that I have. I will distribute as well. Everybody have a good weekend and thank you all for attending. I really do appreciate it. Bye.
Thanks, Marie.
Bye-bye.